Parents of children with AS can typically trace differences in their children's development to as early as 30 months of age, although diagnosis is not made on average until the age of 11. By definition, children with AS develop language and self-help skills on schedule, so early signs may not be apparent and the condition may not be diagnosed until later childhood. Impairment in social interaction is sometimes not in evidence until a child attains an age at which these behaviors become important. Social disabilities are often first noticed when children encounter peers in daycare or preschool. Diagnosis is most commonly made between the ages of 4 and 11, and one study suggests that diagnosis cannot be rendered reliably before age 4. Asperger syndrome can be misdiagnosed as a number of other conditions, leading to medications that are unnecessary or even worsen behavior. The condition may be at the root of treatment-resistant mental illness in adults. Diagnostic confusion burdens individuals and families and may cause them to seek unhelpful therapies. Conditions that must be considered in a differential diagnosis include other pervasive developmental disorders, schizophrenia spectrum disorders, attention deficit hyperactivity disorder, obsessive compulsive disorder, depression, semantic pragmatic disorder, multiple complex developmental disorder, and nonverbal learning disorder. Differentiating between AS and other ASDs rely on the judgment of experienced clinicians. Tourette syndrome, or TS, should also be considered in differential diagnosis. It is non-retarded, rigid individuals on the autistic spectrum, especially those with so-called Asperger syndrome. The differences with less severely affected individuals with TS and OCD may become blurred, or that both disorders may coexist. Other problems to be considered in the differential diagnosis include selective autism, stereotypic movement disorder, and bipolar disorder, as well as traumatic brain injury or birth trauma. Conduct disorder, Cornelia de Lange syndrome, fetal alcohol syndrome, Fragile X syndrome, dyslexia, FAR syndrome, hyperlexia, leukodystrophy, multiple sclerosis, and triple X syndrome. The diagnosis of AS is complicated by the use of several different screening instruments. In addition to the DSM-4 and the ICD-10 criteria, other sets of diagnostic criteria for AS are the Satmari and et al. Criteria and the Gilbert and Gilbert criteria. Compared with the DSM-4 and ICD-10 criteria, the requirements of normal early language and cognitive development are not mentioned by Satmari, whereas speech delay is allowed in the Gilbert and Gilbert criteria. Satmari emphasizes solitariness, and both Gilbert and Satmari include odd speech and language in their criteria. Although Satmari does not mention stereotype behaviors, one of 4 described stereotype functions is required by DSM-4 and ICD-10, and 2 are required by Gilbert and Gilbert. Abnormal responses to sensory stimuli are not mentioned in any diagnostic scheme, although they have been associated with AS. Because DSM-4 and ICD-10 exclude speech and language difficulties, these definitions exclude some of the original cases described by Hans Asperger. According to one researcher, the majority of individuals with AS do have speech and language abnormalities, and a recent DSM-4 says that the occurrence of no clinically significant delays in language does not imply that individuals with Asperger disorder have no problems with communication. The Gilbert and Gilbert criteria are considered closest to Asperger's original description of the syndrome. The aggression and abnormal prosody that other authors say define Asperger's patients are not mentioned in any criteria. The DSM-4 and ICD-10 diagnostic criteria have been criticized for being too broad and inadequate for assessing adults, overly narrow, particularly in relation to Hans Asperger's original description of individuals with AS, and vague. Results of a large study in 2007 comparing the 4 sets of criteria point to a huge need to reconsider the diagnostic criteria of AS. The study found complete overlap across all sets of diagnostic criteria in the impairment of social interaction, with the exception of 4 cases not diagnosed by the Satmari criteria because of its emphasis on social solitariness. Lack of overlap was strongest in the language delay and odd speech requirements of the Gilbert and the Satmari requirements relative to DSM-4 and ICD-10, and in the differing requirements regarding general delays. In 2007, Satmari suggested a new classification system of ASD based on familial traits found by genetic epidemiology. Although individuals with Asperger's tend to perform better cognitively than those with autism, the extent of the overlap between Asperger's and high-functioning autism is unclear. Overall, relatively few differences are reported between Asperger's and autism on parameters related to causation. A standard assumption is that Asperger's and autism have a common cause and are variable expressions of the same underlying disorder. A neuropsychological profile has been proposed for AS. If verified, it could differentiate between AS and HFA and aid in differential diagnosis. Relative to HFA, people with AS have deficits in nonverbal skills such as visual spatial problem solving and visual motor coordination, along with stronger verbal abilities. Several studies have found AS with a neuropsychologic profile of assets and deficits consistent with a nonverbal learning disability, but several other studies have failed to replicate this. The literature review did not reveal consistent findings of nonverbal weaknesses or increased spatial or motor problems related to individuals with HFA, leading some researchers to argue that increased cognitive ability is evidenced in AS relative to HFA regardless of differences in verbal and nonverbal ability.